I'm just showing nice pictures from the architecture in Barcelona. I hope most of you have been visited, or perhaps you are visiting in the next future in our second NIV conference next year. Briefly, I would like you to introduce how is my work environment. I'm working in a public hospital in the South Metropolitan area of Barcelona, right here, in that point. And we are a university hospital working as a children's hospital, and we are admitting 1,000 patients per year in our 14 beds PQ. As most of the units, 50% of our patients need respiratory support. From the beginning to now, really, we have increased a lot the use of non-invasive support in our patients, and nowadays more than 70% of our patients are receiving initially or post-activation non-invasive support. This is the hospital, and this is my figure. So really, I get my position in 1998, starting NIV in a very few patients, and it was when we discovered that we have to train our nursing staff in 2005 that really we got a very steep increase in the number of patients treated for NIV. Obviously, we also got more ventilators because with only one ventilator in the unit during the first years, it was very difficult to treat or impossible to treat two patients at the same time. Really. So really getting more ventilators, we are getting more patients on NIV. You can see the yellow bar is the elective NIV ventilator. Okay, this is a general review of this lecture. First, and we will be talking about that why NIV is failing in younger infants. We'll look to the NIV specific ventilators, those based on a turbine. Afterwards, we'll have a look to what's going on with the conventional ventilators with NIV option. Secondly, we are going to see and review what NIV NAVA offers. And finally, I will, after 3 years of experience with NAVA and NIV NAVA, I will show the strategy in our hospital, Hospital San Juan de Déu, that is it belongs to a religious order, and it could be translated like Saint John of God. So there are several hospitals in the world, so in French, Saint Jean de Dieu, etc. So, and to wrap up the session, I would like to show some critical algorithms. So it's just based in our experience. So we know that we are talking about the lowest level of evidence, but I think it's worth it to talk about it. Well, we know from the data of my unit, this is my thesis with 491 patients treated in the PQ from 2005 to 2009, that patients younger than 6 months have only 65% of success rate. And all the patients older than 6 months has a higher rate of success rate. So it has a very nice statistical significance. So really, it's a key point. So really, we know that technology today is not good enough to provide good NIV and get great results with NIV in young infants. The use of the NIV in my unit has changed over the time, obviously. Since 1998 to 2007, we were really BiPAP lovers, and we were using only CPAP for infants. So all those infants with bronchiolitis, whatever, respiratory distress, failing on CPAP were intubated, 100%. At that moment, we changed our old fleet of Servo 900C ventilators. We had one Servo 300, and we switched to the Servo I ventilator, so with the NIV option. So we're very excited about that, and we started to provide bi-level to those patients failing on CPAP. And finally, we started with NAVA in 2010. Let's go deep in detail with the next slides. So as you can see, we can see that most of our patients, more than 60% of our patients, we were using BiPAP vision even our nursing staff during the holidays, they used to make this kind of jokes. And when we started using servo-I in small infants with bronchiolitis, really we also started to use and provide bilevels. We were using mainly a very old-fashioned interface. Really, it's the endotracheal tube used as a nasopharyngeal tube. So really, it's the only thing we had for very small and tiny infants. And really, it seems that it worked. But see, why was the reason we started to use servo-I? Because the NIV-specific ventilators were failing. The intended use for BiPAP vision, Corina, is for patients weighing more than 20 kilograms. But several papers from my colleagues, Spain, Juan Mayordomo, Alberto Medina, showing that we can ventilate with these ventilators younger patients weighing 9 kilograms. Lassie Lam published in Pediatric Critical Care years ago her experience with more than 300 patients ventilated mainly with BiPAP vision. Also, again, the average was 8 months, more or less. So really, we can go further than the recommendations of the industry about their devices, and we can ventilate. But what happens to our patients if we go further to smaller infants? You can see here in the screen, this is the screen of a brand new ventilator, the V60 from Respironics. And we can see here, okay, in the screen shows you that if the breath is captured, from the spontaneous breath of the patient is captured, is the green line. And if there is no, we assume that is not a preemie doing apneas, is a patient spontaneously breathing, but the ventilator is not able to detect the inspiratory effort of the patient. So we are facing inspiratory asynchrony. Now we have receiving, with the orange line, we are receiving a rescue breath. So a control breath that perhaps is going to deliver volume to the patient or not, because if the glottis is closed, we are not going to get. So synchrony, and especially inspiratory asynchrony, is a crucial issue in infants that is not solved by the specific turbine-based ventilators. What about the conventional ventilators? So really, we have seen from published papers that in batch studies, probably servo-I is one of the best providing and compensating the leaks. And there is only one randomized clinical trial talking about pediatric patients in the PQ. It's published by Yanez, and he was using BiPAP vision for older patients and servo-I for younger patients. So we have the higher level of evidence with a randomized clinical trial, which devices we are using. And we are doing like this. But we have seen that with pressure support and huge leaks, nasopharyngeal tube, it's a mess. It's really terrible. The patient is all the time asynchronic. So we decided to use the pressure control mode that really it's a badly named because it's an assisted pressure control mode. Really, if the patient is able to activate the trigger, he will receive a synchronized breath. If not, he will receive control breath. We can see here in the screen, perhaps will be very difficult. We can close the lights for a short while in order to see the screen. Could be possible? Well, no. We can see here that the patient is connected to the ventilators through a nasopharyngeal endotracheal tube that is inside the nostril 7 centimeters. So, and why did we decide to insert 7 centimeters? To be the closest as possible to the glottis and to capture the inspiratory effort of the patient. Wow, I have to say that it works. Recently published in Respiratory Care, this is our experience. Only 7 patients in 2007 using nasopharyngeal tube with V-level. These are all the ages, so more than 100 patients, almost 200 patients treated each year with non-invasive ventilation. I'm talking about bi-level. CPAP is another issue. And most of them almost 70 each year, the last 2 years, treated with nasopharyngeal tube and servo-I in pressure control mode. Well, it works or doesn't work? Really, it works. We treated 151 patients, and we get a success rate was 73%. So it's the average of all the pediatric studies treating infants, children, older children, etc. But there's a small difference. Those patients without previous respiratory support have, again, lower success rate, only 63%. Patients with elective post-extubation NIV, those patients in a better situation, the disease which caused the respiratory failure is recovering, so we get better results. We can see also, I think it will be very difficult to see, that in pressure control, we have to set very well the parameters. So if we do not set properly the settings, we'll have asynchrony. If we set, a very long inspiratory time and a shorter respiratory rate, we can see here with the white line is the superimposed NAVA level curve. NAVA pressure level with NAVA should be here. We can see that there is inspiratory asynchrony, expiratory asynchrony, that another wasted effort. So really, if our settings are not pretty good, we are going to fail. And I can show you that improving the settings, shortening the inspiratory time, increasing the respiratory time, really we are getting a very good synchrony that NAVA confirms. Really, in this patient, we were not using NAVA, we were just confirming that with NAVA, with pressure control we can do NIV, but it will be easier if you are not well trained with NAVA. Okay, what happened last year? So finally, I get the full face mask. The last winter season was amazing. So really, in 1 month, we changed the protocol, and it's the only time in my life I get positive feedback from the nursing staff. So introducing a new thing and fighting all the time, needing a lot of time to implement, to train your people, and here in 2 weeks, everybody started to use the interface, and we started to move from pressure control to pressure support because no more huge leaks. Patients look wonderful, many of them with a pacifier inside the full face mask and very nice synchrony. But some patients also failing on NIV. So the meat of the lecture, what NIV NAVA offers. So let's see. This paper was published in Critical Care Medicine in 2010, and we can see that in both sides, so really looking at the inspiratory and the expiratory asynchrony, in both sides, NAVA offers better results than pressure support. So here we can see that the inspiratory delay is lower than 100 milliseconds. Working with BiPAP Vision or other ventilators, they are telling you that really you are lower than 150 milliseconds, and it works pretty well. So really, we are even having shorter inspiratory delay. On the right side, we can see that for the expiratory delay, it can be even worse, especially if the patient needs higher levels of pressure support. The asynchrony can arrive to almost 1 second. That's crazy. When that baby with bronchiolitis has an inspiratory time of 0.3, having an inspiratory time of 1 second is absolutely crazy. So you are going to intubate all these babies, and you say, oh, it's not working at all. So it's not working the pressure support with a nasopharyngeal tube with huge leaks, for example. Okay, what more NIV NAVA offers? I think it's very interesting. It's not only about synchrony, it's proportionality. You can see here the EDI curve, at the bottom. This is the electrical diaphragm signal, and this is the getter signal. The patient gets great pressure and greater volume. So who is driving the ventilator? The patient is driving the ventilator. And I think it's very difficult to be faster than the patient to modify the settings in each breath. So really having this opportunity that the patient not only drives the respiratory rate, the trigger delay, so really it's so short. See, even more that we don't need to check the blood gases. Is the patient who is doing the blood gases all the time and deciding to increase the respiratory rate or increase the work of breathing. So increasing the EDI signal, so increasing the pressure and increasing the tidal volume he or she gets. So let me show in 2 slides, which is our NAVA experience that we are also showing in a poster here in this very nice conference. We selected from our short experience with 30 patients an homogeneous sample of 22 patients electively extubated from NAVA to NIV NAVA. Most of them have more than 10 days of mechanical ventilation, previous extubation failure, or have shown asynchrony with some of these devices or strategies I have shown you previously. So we are using as a rescue a strategy because of this, the lack of resources in our not very wealthy country. We can see that the success rate was 74%. You could say, well, it's the same rate, but it's a very, very biased sample because those are patients who are failing on NIV, and we expect a higher failure rate than common patients that I shown previously in the general slides. Okay. NAVA also offers information. In this slide, I want to show you that in our first patients, we saw here our initial NIV not having previous support, respiratory support, and this post-extubation NIV. We can see that the red line, those patients failing on NIV keep an EDI maximum peak over 40 microvolts and going up. And for those patients that initially are pretty stable after extubation, after 12 hours, those who the EDI peak is going up, so clearly the work of breathing is going up, are going to fail. So really, it's a complementary information that can help to the pediatricians to make decisions with these patients. Coming to the end, so I will show you which is the strategy in our hospital. Usually, we start with CPAP only for patients, younger patients that are having apnea, bronchiolitis, or mild disease. All the other patients, we switch rapidly to bi-level pressure, so it doesn't matter. So, which is the barrier? The barrier, we have seen that is around the 3-5 months. So for older patients, in our experience, and all the papers have published, Dr. Mayordomo, Lassie Lamb, etc., the randomized clinical trial of Yanez say that NIV-specific ventilators are working. So those turbine-based ventilators, whatever, we are talking about Corina, we are talking about the VPAP Vision, we are talking even from home ventilators. Nowadays, most of them have blender, oxygen blender, so really can be used in the acute setting. Really, it's our first option, and if you have oronasal or full face mask, is our preferred option. Evidently, we have patients who fail, and we try to rescue with NIV NAVA. On the other side, for those patients that clearly has been shown that are more prone to fail, we are using the same interfaces, but in the first line, we are using conventional ventilator. In our experience, it's Servo-I with the NIV option. In pressure control mode with nasopharyngeal tube, but having now full face mask, we are moving to pressure support with good results. So, but Some patients, we can use V60 with the AutoTac Plus. We have also in the unit the Julia, that is a neonatal ventilator with a very sensitive flow trigger that we are also using for rescue of patients, of infants with bronchiolitis. But when this is failing, we are also using NIV NAVA. You could ask, well, what are you so restrictive? So you are so in love with NAVA and offers so many solutions. Because in the budget of my hospital, I get only 15 catheters per year. So I have 1 patient per month to offer NAVA at this moment. So really, I have to be very restrictive. So I think I have to offer the best solutions I have at hand, that I have a lot. I have a lot, fortunately, in my unit, because we have several NIV ventilators. We have 10 servo-eyes in the unit. We have 2 NAVA modules, but we can only treat 1 patient per month at this moment, paying our national health system. So really, it's a pity, but it's the real life. So finally, I would like to show some clinical algorithms. So it's a very short sample. We are just giving this to our nursing staff, my doctor and my colleagues in the unit, because the first answer to when something is wrong with NAVA is switch off. And it's very easy to switch off and change to another mode or to another ventilator. So really, it's a way not set in stone, really, to facilitate and to manage this new mode. So usually, if our patient is tachypneic on NAVA, we don't feel comfortable. So it's more tachypneic than I expect. So really, I start to be concerned. So I differentiate clearly those patients who are not comfortable from those who are comfortable. If you look at patients that are comfortable and the EDI peak is in the normal range, 10 to 20 microvolts, okay, wait and see. The patient is driving, it's very wise. He has a lot of experience in mechanical ventilations. I think that the brain has 100,000 years of evolution. And even in the premise, have all inside this software. Okay, so the ED peak is going up. We have to be concerned, and we have to consider those patients who are severely hypoxemic with SF ratio, that is an alternative to PAFI ratio, using the saturation, and we will check the X-ray to decide if there are atelectasis or lung edema, etc., and we can increase the NAVA level or increase the PEEP in these situations. Especially very common, EDA peak is very low, less than 10 microvolts, then check the EDA catheters. This is the Achilles heel of the system, really. The catheter position has to be checked, and if it's okay, then there are the first barriers on NAVA. We are doing over-sedation, and we are doing over-assistance to our patients. You have to learn that. Even if you don't have NAVA, you have to switch your patients to pressor support to check that they can breathe and they can use the diaphragm, because they can do earlier that we think. And really is that the main thing that NAVA showed to me and explained to me, that really we are currently over-sedating and over-treating our patients. So we will skip these other parts of the algorithm, just checking of those patients who are not comfortable and have an EDI peak greater than 20 microvolts. Again, if the patient is hypoxemic, check out the leaks, adjust or change the interface, and rule out massive atelectacy. Adults have shown that massive atelectacy and lower pH are a contraindication to continue on NAVA. On the other side, we have seen some patients that were doing very well, no hypoxemia, normocapnia, but they have withdrawal syndrome. So really, we have to start again and going up a little bit with the opioids, because the drive was so high that the patient was not comfortable. So it's we have seen in the last months, this year, and this is another option that we added to the algorithm. We are going to skip those. So just for greater levels of 40 microvolts, really, think about air obstruction. It could be tracheomalacia, it could be croup, so then add iliox or increase the PEEP. So which are my take-home messages? NIV NAVA offers synchrony, proportionality, gives us more information, and I believe that in the near future may play a role providing bi-level pressure in the most challenging patients, that for me are infants and neonates and asynchronic patients. Thank you very much. Perhaps we will be able to give another use to our laryngoscope blade. Thank you very much.